I'm Holly Red, and I'm presenting our poster on investigating the effects of externally guided movement training for individuals with Parkinson's disease. I worked alongside Bruce and Erica and Danielle and Maggie, I'm mixing up the names, under Dr. Hack with the Tango group. So, our participants were specifically persons with Parkinson's disease, and as most of us know, Parkinson's disease is a neurodegenerative disease involving a depletion of the dopaminergic neurons in the basal ganglia. Now, this disease affects movement, autonomic function, cognition, and psychosocial function. And specific to all of these functions, we're going to be addressing the physical, cognitive, and psychosocial domains that are affected in these persons. We have found in our literature review that use of external cues can improve movement. So when you use like auditory, visual, and tactile cues in persons with Parkinson's, it can help them improve their movement. So if you've been in clinic and told your person to take bigger steps or improve their arm swing or stand up straighter, then that has a huge effect for them because they can take in that information and spit it out into better movement. So this is because in Parkinson's disease you have the striatal-thalamocortical circuit, which helps integrate and perform internally guided movements. This is me saying I'm going to step forward and actually being able to fully complete that motion. This is effective in moving in persons with Parkinson's because of the degeneration of the basal ganglia, whereas the cerebellar-thalamocortical circuit is overused in a compensatory manner in Parkinson's disease and works with the cerebellum and the cortex to perform externally guided movements. This is taking in all of your cues from your physical therapist and turning it into improved motion. In former studies, adapted Argentine tango improved mobility, balance, quality of life, disease severity, and spatial cognition in persons with Parkinson's disease. And the main reason we're looking at Argentine tango is because when you split the leader and follower roles, you have your leaders performing internally guided motion, putting the followers through their motions with externally guided cues. So you get to really tease out the STC and CTC tools. In previous studies that Dr. Hackman performed, participants danced both the leading and following roles interchangeably. They just switch every time or every 15 minutes. So this particular study, we're looking at specifically leaders versus specifically followers and trying to separate those out and see what the effects are. Our hypotheses are that not only will the gains be greater in the followers than our education control group, but that the leader group is going to improve over both of those groups. So for our methodology, we performed pre-test 20 classes that were 90 minutes long, either the adaptive tango or the education seminars. Post-test immediately afterwards, followed by a 1-month follow-up assessment. Our demographics looked about like this. We were fairly well matched for sex, age, all of this business. They were around 70 years old, had about 5 to 7 years of Parkinson's disease. They had around a bachelor's degree in education, presented with around 3 to 4 comorbidities, and were on around 5 to 7 medications, which, as we know in PT school, having 5 or greater medications is considered a fall risk. The Hoehn and Yahr score was around 2.3, give or take. Now, this is a scale from 1 to 4 that indicates the severity of their progression to Parkinson's disease. So the fact that all of ours were around 2.3 means that they're beginning to show bilateral symptoms, where a 1 is unilateral and 3 is progressively worsening bilateral symptoms. They showed low to moderate feeling of falling, had high to moderate quality of life. Their composite physical function showed that they were kind of at risk of further losing their physical function. This was a series of questions that asked about things they can or can't do or can't do with help. The Montreal Cognitive Assessment showed our participants to be quite cognitively intact. About a third of them used an assisted device. One thing worthy of note, we had a report of about 5 falls per year per participant, which we kind of think is a pretty high number. The thing being, some of our participants fell as few as 1 or 2 times per year, and some reported as many as 20 falls per year. So obviously that's going to pull your number up, and this is something to watch for people with Parkinson's. So, in the adapted tango lessons, we would perform a warm-up followed by partnering exercises, learn the step of the day, and then do amalgamation, which is when we get to bring together the steps that we learned that day as well as steps that we learned in previous classes, and they just get to go and practice. And our Parkinson's participants were matched with healthy controls, so like all of these lovely DPT students as well as healthy volunteers from the community, and sometimes our participants would bring in their spouses as well. So as you can imagine, that got kind of fun, just grabbing I get one. Okay, let's go tango. So they were specifically assigned leading or following roles and participated in 20 90-minute classes. And this had like one structured break to make sure they didn't get exhausted. We also encouraged them to take breaks whenever they needed to. They just got out of breath or a little overweight. And then we had our education group in which they participated in 20 90-minute health education seminars. This was looking at things like vision, renal health, exercise, cancer, even. We covered many different topics. And at the end of these health education seminars, we would involve everyone in group discussions. This controlled for the social interaction that we saw in the Tango classes. We performed repeated measure ANOVAs on these selected measures. So we're going to move on to our results now. Specifically, we had a bunch in the physical domain, the cognitive domain, and the psychosocial domain, and we're going to look at some particularly interesting findings in these 6 graphs. First, we have, for all of these, the purple line is going to be our follower tango group, and the green line is going to be our education control group. We specifically just looked at the pre- and post-test assessments because all the data isn't in for our follow-ups and nor for our leaders just yet. It's just a nice little preliminary snapshot for you guys. We looked at the dynamic gait index, 6-minute walk test, Brooks spatial task, geriatric depression scale, UPDRS Part 3, which is the motor examination, just looking at what kind of symptoms they have and their disease severity, as well as the Part 4, which is motor complications, looking at dyskinesia, dystonia, its effects on their emotions during the testing, as well as effects of medication fluctuations. So, specific to the dynamic gait index, we noted that the follower group improved over the education group. We also saw a very similar story with a 6-minute walk test, again, so follower group improving over the education group. In the Brooks spatial task, not only did the education group not appear to improve very much, but the follower group started a little bit lower and improved over the education group. We also saw in the geriatric depression scale, this was a self-reported depression symptom scale. What was kind of interesting about this is that while both groups did decrease their reported depression symptoms, this was really consistent with the work done by the 2014 DPT group alongside Dr. Hacking, where they showed that the education group did improve over their tango group at the time. So, not at all surprised by this and kind of need to back up their data. So, for the UPDRS Part 3, again, both groups improved, but followers greater than education. And then for the motor complications, what we thought was kind of interesting here is that while the follower group did improve just a little bit, the education group may have actually gotten just a touch worse. More findings that we thought were notable is that the participants reported increased physical activity in both the education and part of the tango group. We also saw executive function, planning, and organization improving per the Tower of London, as well as cognitive flexibility per the color word interference test. And this improved in both groups, but may have improved more in the follower group once again. So, furthermore, no change was noted in the body position spatial task. We found this was of particular interest because the body position spatial task is our main outcome measure to assess the function of the STC circuit. In this one, we kind of brought people together and asked them to perform a series of walking steps and turns in a certain order. We only gave them the cues, showed them how to do it, and then stepped back and asked them to show us what they remember. So they had taken this information and immediately turned it into a motor claim without further cueing. While neither the follower nor the education group improved, we're really hoping to see that the leader group comes back with data that shows that they did improve because we've been training the STC circuit by putting them through leader. Last point. These are preliminary findings and should be interpreted very cautiously because we've only run a group by time study for just the follower and education groups. And we would like to show our appreciation for Dr. Hackney and Ariana Resorg for all of their assistance in allowing us to take place in their study, and Ms. Rhonda Coutinho for her assistance with the instruction of the adaptive tango classes. Any questions?
Talked about the medications. I might miss this when you said it, but did y'all control or take into account that the Parkinson patients were on medications for the disease, or?
So During their testing, we actually require that they be off medication for at least 12 hours to see what their symptoms look like. So this is enough time for all of the medications to have gone out of their system, regardless of what regimen they're on.
We did not control how many.
Exactly. We didn't control how many, but if they were on, we made sure they were off. That they were all off during testing. Yes. However, during the tango, we required that they be on their medications. That way, they could get the most improvement out of it possible. Any other questions?
I have a question.
Yeah. Mom?
You didn't have to identify me. Not understanding exactly what the units are in your measurements, have you accounted for the possibility of why there's a large disparity on some of the starting points for some of your measurements?
So we actually haven't performed those particular statistical tests yet. However, one thing that we can note is this is not a 0 to, it's like not a full scale of the tests in and of themselves. And the nice thing is what we could see is that in standard deviations for the vast majority of these tests, they did overlap. So there's just some really appreciably good matching between our groups.
Okay.
Why tango over any other type of dance?
So the nice thing there is that Dr. Hackney started as her interest was in dance, and she began her studies in working with the elderly, and saw great improvements. Then they got to see it in a stroke group before they moved on to Parkinson's disease and saw further improvements. And she's been working with Parkinson's patients ever since. Any other questions?
Were any of the patients in the study or the subjects in the study getting skilled therapy outside of your guys', or like any interventions or anything like that may have?
They're not supposed to. They're not. We requested that we catch them during a time when they were out of therapy, and that they not start any new exercise regimens during the study. That's not to say they necessarily didn't, because in some cases we did have. I think we had a participant who stroked towards the end of her issues, so I would expect that she got therapy. I really hope she did. But for the most part, we did ask that they try not to.
So with the education, because I know it said that they had an increased physical activity level.
Yes.
So with the education, they're educating them on physical activities as well.
Sure,
Okay.
yeah, that was definitely a subject of more than one seminar, I believe, looking at different forms of education as well as other types of health. Because when you look at health in any case, a lot of these professionals are coming in and say, make sure you exercise because it will decrease your effects of pretty much everything. So while we did ask them not to start any exercises, I believe that some of them did, just to get on the right track.
Was there a large range in the education for some of these, I guess, some of the outcome measures that you were looking at based on their that correlated with their physical activity reported?
For like there's
So like, how many people actually took heed with the education, I guess?
Yeah, so we actually got some pretty neat findings of that. With some of our people in the education group, it was rare for them to ever see flight of stairs, and they would just walk around in their homes. And with some of them, they were walking 5 miles a day and intentionally climbing stairs to keep up their exercise levels. So we really had a broad range of physical activity within both groups.
And it was interesting, just the Parkinson's social groups available. We participated in some PD gladiators in Delgado Boxing Gym, and after their study was completed, they'd made connections with other Parkinson's individuals, and then they were wanting to go and do other kinds of activity after. So I think that was a huge thing. We loved that social interaction.
Absolutely. And that's something that we encourage too. Not that, because once they were finished with the study, we really want them to continue improving. So facilitating those interactions was really neat. Any other questions? Does anyone want to try the body position spatial task or some tango?
Let Charlie do it. Yes, Charlie.
Sam, you want to come up?
Envision you doing this.
All right. So we're going to keep this easy. I'll do the body position spatial task.
Perfect.
Okay. So what we're going to do, actually, is hands off, but that's okay. What we're going to do is I'm going to teach you a series of walking steps. Okay, so I'm going to give you instructions so we show you what you're going to do, and then you're going to use the instructions. Okay? We're going to start with a 2-step. We're going to go forward step, turn left. Go ahead. Awesome. And now we're going to do another one. This one's going to be 3 steps, okay? So go ahead. Perfect. We're going to do turn right, step left, forward step. Go ahead. Perfect. Okay. A lot easier for me to say because we show what our participants do.
Oh.
No, it's okay. It's actually kind of interesting because people will get to about this stage and you'll start seeing their first mistake. At each you would have two 2-step, 2 3-step, 2 4-step, etc. And if they failed both within a set of number of steps, that's when they are actually finished with the process. So we're gonna do a 4-step now. We're gonna do a forward step, turn right, forward step, step left. Go ahead.
Yay! Great.
So that's body position spatial task. Now, given all of this, you can see why this would be important for the internally guided motions. There's no further cueing. They get the instruction once and are expected to do it. And that's really similar to how the tango class is formed. Anything else?
Great job.